Hi, everybody. Thank you so much for joining our webinar today, where we will be talking about menopause, the bladder, and the vagina. This is such an important topic for many women, as subtle changes to the bladder, vagina, and pelvic floor muscles can start early in our menopausal transition and usually have peak symptoms that often stick around many years after. My name's Kim Fancher, and I will be your host today. We here at Positive Health are so honored to be able to bring experts in to share some really great information on menopause topics like this one that are important to you. So now let's get us kicked off here, and I am thrilled to introduce our guest presenter, Dr. Lauren DeWinter. As a urogynecologist, she treats pelvic floor conditions, urinary and bowel leakage, recurrent bladder infections, and vaginal prolapse conditions that start for many women around this time of menopause. So thank you so much, Dr. DeWinter, for being part of our Positive Health webinar series. I think we would all be interested in hearing about your career and how you got started in this space, if you don't mind sharing that with us.
Oh, yeah, sure. So I'm Lauren DeWinter. It's nice to have the opportunity to do this. So I was originally trained as an obstetrician gynecologist, and I went into urogynecology through that. So I went through medical school at Baylor College of Medicine. I went through residency for OBGYN at Harvard at Brigham and Mass General. And then I went on to do fellowship in kind of get cross-trained in urology, so specializing in the bladder, and reconstructive techniques in gynecology. So an extra 3-year fellowship to learn more about surgical techniques and the medical treatment of women, mostly in menopause. So the majority of my patients are over the age of 50. I did that at the University of New Mexico, and now I'm in Long Beach, California, and I opened my own practice about 1.5 years ago after being here for a few years. And I have a partner that I work with at Praxis Urogynecology in Long Beach. And so I'm passionate about women's health, and I'm very passionate about taking care of women going through the menopause transition and kind of what the changes to the body are after, because it very closely relates to my both medical and surgical practice. And so that's why I was invited to chat about this, I think. So today I just want to talk about what kind of changes happen to the bladder, what happens to the vagina, and what treatments are available out there for managing these symptoms and managing the medical conditions that happen because of them. And then I would love to take your questions to see if there's any additional things that I can clarify or any points of interest that I missed. So as an introduction, most people know menopause happens in women's usually between 45 and 55, with the average age at this point being 49. Used to be 51. I don't totally know what happened, but it seems like it's getting a little earlier, or our data is a little different. These subtle changes, though, that can happen to the bladder and to the vagina can actually start years before menopause happens, because your hormones start changing a little bit even earlier. A lot of women in their 40s start recognizing having a little more vaginal dryness with sex, a little more fragile tissue in that area. And some changes to the pelvic floor muscles can also start around that time. But the very peak, the most symptoms of menopause people notice happen after. They're like, why is this happening now? I'm 5 years out, I'm 10 years out. That's usually when you really get those changes to the vagina. Because as a concept, hormonal changes happen kind of slowly. They affect the body in the course of sort of months to years, as opposed to days or hours that some medications do, right? But hormonal changes happen very slowly and persist for a long time until that hormone is withdrawn completely. Everyone thinks about the sort of estrogen loss side of things, which is as you hit menopause, you lose all of your estrogen. And then all these things happen because of that. But there's also hormonal changes that are androgen receptors. Androgen receptors are kind of thought about like testosterone, male hormones, DHEA. And women make those too. And women make those hormones in their ovaries. So the changes that happen at menopause affect the estrogen levels and they affect the androgen levels. And so on the estrogen side of things, your vagina, the urethra, the tube you pee out of, the pelvic floor, the muscles, the adventitia, the tissues, they're all very, very sensitive to estrogen changes. And when menopause happens, you get an abrupt drop in the levels of estrogen. It does drop really precipitously. And so these long-term changes can take years to fully happen. But they make a huge amount of difference in sort of how you feel and how your body adapts to stresses. Androgen loss, which is those testosterone, DHEA receptors, those are present a lot in the vulva on the outside of the vagina, but also in the pelvic floor muscles and the ligaments. And the ovaries do make testosterone, and that starts to drop off after menopause as well. But it's a slower decline. And so all of these changes can sort of affect the bladder really, really powerfully. And so this is a drawing of the bladder, and it kind of shows the different parts of it that I want to go over. And so on the next page, I may flip back and forth so I have a little picture of it because this is a nice big one. But I want you to know the key terms so you know what I'm talking about. So the detrusor muscle is the muscle of the bladder that squeezes to make you urinate, or it relaxes so you can store urine. On this page, you can see that there's a muscle band that is around the outside of the bladder. That's kind of the thicker part of it. And so that's really important because how that muscle squeezes directly relates to how your bladder feels and how urgently you feel like you need to go to the bathroom. There's the mucosa, or the smooth urothelium, the surface of the bladder on the inside. And that's that smooth surface that the urine touches, kind of inside of the, I'm going to say water balloon is what it kind of looks like, but it'd be what touches the water on the inside. And the last part is the urethra, which is the tube that comes out of your body between the clitoris and the vagina. It's that third hole people forget about sometimes because they think that they're peeing out of their vagina. I get asked that all the time. Separate holes. It can withdraw a little bit into the vagina when you go through menopause, so people aren't wrong. It does seem like it's coming from the same spot sometimes. So the urethra is really, really, really important for continence, not leaking on yourself. So staying dry, a lot of it has to do with the tube you pee out of. And that tube that comes down at the bottom here, it has all those lining features, kind of like the bladder does. It has some muscle, it has that urothelial lining, and it has the ability to close when it needs to close to keep you dry. It has several different muscles on the inside and the outside, but the main point I want to make here is that it is delicate. Those tissues are very small in size. The muscles are very, very small, and they're easily damaged. And so I want you to keep that in mind as we talk about what can happen to the bladder. The changes with menopause are pretty profound to the bladder. Your urethra, the tube you pee out of, actually becomes shorter in length. The average lady kind of has a 4 centimeter urethra when she's in her 20s and 30s. And when you get to women in their 40s and 50s, 60s, 70s, 80s, you end up having a shorter and shorter urethra, which has a lot of changes. It'll make a lot of changes to your functional ability with it. Men have these really long urethras that go all the way through their penis, right? It's easy for those to close down and not leak urine. But when your urethra started out this long and becomes, 2.5 to 3 centimeters or less sometimes, it is really hard for your muscles and for those pillows on the inside of the urethra to close up so urine doesn't leak out. So stress incontinence can happen. I'll talk about that more later. There's also the possibility that because it's a shorter length, bacteria, it has less of a course to travel to get into your bladder and cause bladder infections. And there's less of a seal on the inside, so it's easier for it to get inside. Those changes are precipitated primarily by estrogen. Estrogen is the big driver of those changes. You also have changes to the lining of the urethra, that tube. It gets less fluffy. It gets less full of blood. It gets less, it's like cushions on the inside of the tube become more open. And when those tubes become open, it is much easier to leak urine from there. And the muscles start to lose a little bit of their muscle mass. And when they start out so small, even a tiny amount of muscle loss makes a huge difference on how well you can control your bladder. There's also changes to the bladder wall itself, to that muscle. and the muscle is no longer easy to accommodate. It's not as stretchy. It's not like I'm trying to fill up with urine and I just get really full and I don't even notice it. The walls get stiffer with the lack of estrogen. And so less urine is able to fill into the bladder, so you go more often, and the stiffness causes more overactivity. It causes more of the sensation to your nerves that like, oh, I'm full, I've got to go right now. And so women end up in those situations. So the big medical conditions that I take care of in my practice because of these changes of menopause primarily are stress urinary incontinence. It's not because you're stressed. Everybody asks me, is it because I'm stressed? I'm like, it's not because you're stressed. It's because stress, strain, or pressure is applied to the belly, to the abdominal muscles, to that area, and it's pressed down on the bladder. And when your bladder gets pushed on, that little short tube that just got shorter because of menopause has a hard time holding urine back. A lot of women were like, what caused this? Why did I get this? And I'm like, it's because most of it's because of babies, long-term constipation, heavy lifting. And they're like, but I had my babies 20 years ago. Why am I having this now? It's because when menopause happens, those things that you did to compensate after you had your baby, to not leak urine, start to alter, change, and diminish, right? So that long urethra you had is shorter. Those muscles you had are not as bulky or as strong by themselves, right? And you don't necessarily have the closure mechanisms that you had in the past. And so women start to leak more urine for all of those reasons. And then on top of that, unfortunately, a lot of women get overactivity. And when your bladder squeezes at the wrong time and you don't have the support to hold it back inside, both of these conditions, the stress incontinence and the overactivity, work together to make women really leaky. And so overactive bladder, if anyone's heard that commercial from the 90s, gotta go, gotta go, gotta go right now. You know what I'm talking about? It runs in my head on a daily basis because of my job. But it is exactly what my patients describe. They say, I go out and I know where every single toilet in a 3-mile radius is. I know where they all are. If I go out, I know I track them all down, because when I need to go, I don't have time to delay. I don't have time to slow down, or I will leak on the way to the bathroom. Women get up more at night. So nocturia, nighttime urination, going more than 2 or 3 times a night, waking you up, disrupting your sleep. All of that can be attributable to some of these changes you get from menopause. There are also changes to the nerves in the bladder that are affected by low estrogen. And so the lower the estrogen, the more hypersensitive nerves can get, and the bladder wall gets stiffer. And so you go more often, you go more urgently, and you leak because of a lot of times a combination of these problems. But you have to take care of both of them or you will still leak. So it's hard to get your brain around both of those. There's also some urethral conditions, some changes to the tube you pee out of that you can see that a doctor may tell you about. They're like, you have a caruncle, and you're like, that is the strangest word I've ever heard. You are correct. It's basically on the lower part of the urethra that there becomes it kind of looks like a little pink protruding tongue that comes out. And that is just part of the urethral mucosa, the lining on the inside that comes out a little bit. It's nothing that's going to hurt you. It's nothing that causes trouble for most people, and you don't have to remove it. And treating it with estrogen can help it go back inside because it's driven by estrogen, right? A little bit of estrogen cream can sometimes cause that to pull back inside, makes the urethral tube a little bit longer functionally, and makes you stop having that. You can also get urethral prolapse, where the whole urethra inside tube kind of pouches to the outside, so that lining mucosa comes outside. If you have either of these conditions, if they're not bothering you, causing urgency or bleeding, you don't have to do anything about them, but it's just good to know about in case somebody points it out to you or you look at yourself in a mirror and you see it. So I see a lot of bladder infections. So a lot of my practice is taking care of women that go through menopause, especially, that end up getting these recurrent bladder infections. And menopause greatly increases this risk. A lot of women are like, I never had them when I was younger. I never had had intercourse and had UTIs like a lot of my friends did. And unfortunately, it can happen after menopause, not by anybody's fault, just by those changes we talked about. I'm going to talk a little bit about the microbiome, which is the bacteria that lives on the surface of the bladder, the vagina, and that contributes to a lot of the reasons people get tilted and kind of pushed into getting infections. Of note, vaginal estrogen can be really helpful for these. So when I talk about the microbiome, it is popular right now. Everybody's into the gut microbiome, they're into the skin, they're into the lung microbiome, because in the past, we all just kind of tried to murder bacteria that was bad, not taking into consideration there's a lot of healthy bacteria that lives on us, in us, that keeps our body functioning normally. So for a long time, we've had these really broad spectrum antibiotics that would kill off the bad bacteria, save our lives, extend human life for much, much longer than we had in the past. But the problem is we were destroying or killing some of our healthy stuff that was keeping us safe. So we've gotten all these funny bacterial infections that happen because we killed off our healthy things that were protecting us. And so on the surface of your genitourinary tract, which is just your vagina and your bladder, you have these really healthy bacteria called lactobacillus. The one that we really love is Lactobacillus crispatus and Gasseri and all of these. They're so good at keeping a healthy environment that makes lactic acid. And acid in the vagina and acid in the bladder helps prevent bladder infections naturally without you needing to take antibiotics, without you needing to take pills and potions and powders and things to keep you from getting them. And so just bringing back your healthy microbiome is as effective as taking a daily antibiotic to prevent bladder infections. So it's a huge part of my practice to help women break the cycle of infections. When you lose estrogen and androgen, that balance is so different. If you look at the microbiome of women that are in their 20s and women that are in their 60s, totally different bacteria grows. And that's a lot of the reason that these changes happen. And so I'm going to get into a little bit now about what happens to the vagina. Why does it change at the time of menopause? Why are you getting these funny symptoms? What can I do about them? What's out there now? And so we're going to go through all of that next. So the vagina has a lot of layers. And so on this picture here, on your left side is a vagina that's in a woman that is in her 20s, 30s, 40s. On the right side, it's showing a vagina for somebody that's in their 60s, 70s. And so you can tell, first off, if you're just looking at the vagina with the dotted line splitting it in the middle, that on the right side, the tissue is very pale. It's a different color, right? It looks different just by looking at the tissue. Your gynecologist can see this. It's a clear thing whenever we're looking at the outside and the inside of the vagina that there's a color change. And that change happens because the wall of the vagina changes in its thickness. It no longer is kind of thick and takes a lot of impact. It becomes thinner. It has less red kind of blood vessels that are going to it. The thickness of the skin on the inside of the vagina gets thinner. So every single layer, from the skin to the muscle to the blood vessels underneath it, all get narrower and thinner. And so there's these things called rugal fold or rugae along the vagina that you can see these little folded areas. And those are in women that are premenopausal. You can see that they completely flatten out for women after menopause, often in the lack of estrogen. These folds help you when you're having sex, that things can stretch more. It's sort of a ribbing mechanism, and it helps the vagina stay more dynamic to accommodate for having a penis inside of it, or a finger, or anything that you want to put inside, a toy. And so when you lose that and it flattens out, it doesn't accommodate as well. So instead of being stretchy, wet, it becomes more thin, tender, delicate, more able to tear and less able to stretch. And so there are things you can do about this. You don't have to just say, this is my life, right? So these changes as a whole are called genitourinary syndrome of menopause. So if you're looking for information online, look up GSM, and that's the modern term for vaginal atrophy, because it now includes the urinary tract, my part of things, right? And so it kind of acknowledges that it's not just the vagina that gets these changes in women, it's the bladder and the urethra as well. And so this syndrome kind of like we talked about, makes a thin or fragile vaginal wall. It changes the color of the tissues. It shortens the vagina. It kind of lowers the amount of natural lubricant that you make, because those blood vessels bringing in blood flow to the vagina, when those vessels get smaller, they can pass less water across the vaginal wall, so make less lubrication. And so that indirectly causes that change. You can also get changes to the vulva, and that's from estrogen, but it's also from testosterone. A lot of the structure on the outside, those little labial lips, the big labial lips, those are driven pretty heavily by androgens. And so it's not just your estrogen loss that changes and sort of flattens out those over time. It actually is some of the testosterone that you lose over time. So this can result in medical conditions. If your vagina is thin and pale and it doesn't bother you, it doesn't bother me. It's not gonna, and you don't have bladder infections and you're not leaking. If you just live your life with atrophy, it doesn't matter. Like, it may not hurt you or bother you. When it starts to bother people is when you get pain with sex, right? Painful sex is a huge problem, and it can start at menopause, after menopause, or for some unfortunate ladies, before menopause. And so these changes can cause dryness, issues with insertion, difficulty with orgasm. And a lot of women have trouble with libido. They don't want to have sex because it hurts. And when something hurts, you don't want to do it. It's not motivating to do. So people are like, what's wrong with me? Why do I not want to have sex? I'm like, is it comfortable? Does it feel good? And they're like, no. Like, you're not crazy. Like, it just doesn't feel good. Nobody's going to want to do that. It can even make some women have bleeding or spotting because the skin is not stretching anymore like it's supposed to. It's pulling or tearing. Some women have described it as feeling like they're getting cut. And not all women have this problem. This is not a sentence that everybody's going to have, but I want you to keep an eye on it right ahead of time. And so if it changes start, you can get on top of them before they start being really bothersome. Around the time of menopause, you can also get issues with vaginal prolapse, which is a condition that I take care of a whole lot. I'm bringing it up here because there are changes that happen at menopause that directly cause your bladder, your uterus, or your rectal wall to kind of push down or fall down more, leading to more bladder or bowel problems, or you can just feel something in your vagina. It's basically a hernia. Like, you can get a belly button hernia where your belly button pops out like an outie. That's the same thing in your vagina. Your vaginal walls can push out or fall down or even fall out of the body. It's not mean because menopause is going to do this to you. There's just things that happened years ago, right? They're like, I had my babies years ago. I had that 9-pound giant head baby 20 years ago. Why is this bothering me now? And it's because with menopause, you lose some of the muscle mass that was holding things in. A lot of women gain weight around the time of menopause. It's a hard problem, especially around the midsection, and that pressure pushes down. The uterus that used to be the size of a fist becomes the size of a thumb, basically. And so when you have this shrinking of the uterus and it gets smaller, it's easier to fall down your vagina and drag the walls down with it. And so I end up seeing these women that come at the time of menopause with all of these concerns, and they're like, why now? This is why. It's the loss of those hormones. It's the changes to the muscle. And so what do we do about this? How do we overcome this discomfort? How do we overcome these medical problems? How do we make this better? This is sort of the most important side of things, right? And so for the direct changes that you're having from menopause, the genitourinary syndrome of menopause, a lot of women do systemic hormone replacement therapy. And by systemic, I mean estrogen, sometimes progesterone for your whole body. Some people, this is hormone replacement therapy. This is the stuff that got really scary 20 years ago, but isn't scary if you do it right. This is like using patches or pills orally to work on hot flashes and night sweats and increase your bone density. There's a lot of FDA regulated products out there that do this, and they work great. It takes a while to affect the vagina and the bladder. It's not instant. People are like, well, my hot flashes went away within a week or whatever, but my vagina doesn't feel right still. And because it takes a lot longer to change the actual tissues than it does to change how your brain is managing heat and things like that. Those hormones hit fast in the brain, they do not hit fast in the tissues. And so you have to be patient. It can take a few months before you're going to notice a big difference in your bladder and your vagina. There are two different ways people go about doing hormone replacement therapy, and that's not the sort of scope of this lecture. What I'm talking about today is how it affects your vagina. And the only point I really want to make is that people use bioidentical products or they use FDA regulated products. They hit the receptors in the exact same way because often the hormones are the same thing, right? We use estradiol for the, FDA regulated products. A lot of times that's what they're getting compounded in these bioidenticals. It's either estriol or estradiol. And estradiol in a FDA regulated product is bioidentical. It's a plant-based bioidentical product. So making this nuanced and saying one is better or worse than the other or one is safer than the other is not accurate. And so whatever you choose, just do it safely with somebody that knows how to do it and knows how to dose you correctly and monitor for any abnormal symptoms. When you do hormone replacement therapy, some women do estrogen alone. Some women with a uterus, they need to use progesterone. The progesterone doesn't seem to make as much of a difference for GSM, for atrophy, or for the bladder. It's really the estrogen component. The testosterone that is not FDA approved in the US, but is used in Europe, we use sometimes in a compounded form that we use topically on the outside of the vagina. Some women do really well with an estrogen and testosterone cream on the outside. So that is more of a local or a topical hormone, but some women do pellets or topical testosterone that's for their whole body. There's not a lot of data of what that does to your vagina and your bladder, but probably good things. I would not estimate, and I have not seen that it hurts anybody, but it's not the main thing that I would go for. If you're like, my symptoms are dryness, my vagina, the outside, I want it to feel like it's more back to where it was before. I really, really like topical, vaginal, or local hormones, ones that are just applied to the vagina, in the vagina, and on the outside of the vulva, the skin on the outside. And the things that are, FDA approved right now are estrogen, which works great. It is one of my favorite things to give my patients. I love vaginal estrogen. It is cool. It's cool because you can use it until you're 100 years old and it's safe. There's even been lots of studies on women that have had breast cancer that was receptive to estrogen, that the estrogen drove the cancer. And 5 years out from their diagnosis, our big medical kind of authority in the US completely supports the use for GSM for women that have had breast cancer. So it's not saying that you've had breast cancer, you've had uterine cancer, and you can never use hormones again. It's actually so low dose and so safe that our governing bodies and doctors and cancer doctors all say, if it's bothering you and this is something that's making your life bad, we think it's safe to use. You should always take this advice from your doctor and your oncologist, but it's something that you can bring up and talk about because there is really pretty good data at this point about it and some position statements from ACOG. This is not the same thing as using whole body estrogen. That is a different situation, but topical, meaning a little dab of cream you put on 2 times a week, a little pill tablet you put into the vagina, or a suppository 2 times a week. That does not go above your levels of your hormone in your blood. That makes it above the menopause level. You're still in the postmenopausal level when you use that, meaning it's not going to help with hot flashes. It's not going to help with mood swings, night sweats. None of that will get better, but your vagina and your bladder will. So there are other treatment options for GSM for women that are like, I hear what you're saying, lady, but I am not interested in using hormones on my vagina, and that's okay. I get it. Everybody has a different threshold for what they want and what they're interested in. There's women that have just gone through breast cancer therapy and they can't do it yet. It's just not an option for them. For a lot of those women, I recommend a vaginal moisturizer. I think of a vaginal moisturizer sort of as a product that you use like you would use moisturizer or lotion on your legs or your body to keep the skin flexible and soft and moist on a regular basis, meaning you kind of have to use it every day or every few days to keep it up. The one I really like is hyaluronic acid. It's Reverie. There's a bunch of different brands that you can get it under, but hyaluronic acid with or without vitamin E oil seems to work really, really well for dryness, atrophy, sex changes, like the changes from that happen with intercourse from menopause. There's also glycerin, which is like Reverie or Replens. Nice product. I think it's a little sticky. Some of my patients really like it though. There's been some research studies on apricot or apricot kernel oil, which is used inside the vagina and it can be used daily as a moisturizer, or even buckthorn oil, which is used orally. There's 1 or 2 studies on that, which are interesting. I have not used that myself, but it is something that's out there. The other things that you can use are not daily or sort of to give yourself a really soft, nice, normal vagina, but to use as needed when you have intercourse. And when you have intercourse, a vaginal lubricant is highly recommended, right? Even women that are 20 years old, right, and are having sex, vaginal lubricants will make them have more orgasms. So everyone should use a lubricant, in my opinion, because it's not going to hurt anything and it will make things potentially better for you chronically. There's a bunch of different kinds of lubricants, and the kind of lubricant you use before menopause and after menopause might be different because the change, like your body is a bit different. Your ability to have an orgasm might be different. It might be the same. Your partner may be different. It may take them longer to have an orgasm. So meaning you have sex a bit longer. And so different lubricants may be better at different times in your life. I really like silicone lubricants because I have never had a patient have an allergic reaction to a silicone lubricant. It is really inert. It's very slippery, and the hotter it is, the warmer you are, the longer the sex goes, the same amount of slippery stays. Same thing with an oil-based lubricant, coconut oil. Some people use olive oil, which feels like it would smell a little funny, but I mean, whatever you're up for is fine. And that's going to be a nice lubricating oil that keeps that tissue moist. It helps keep all of that friction and that sort of pulling or tearing sensation down. So some women can go years and years without having to do anything but just use a vaginal lubricant. That's totally fine. Water-based lubricants after menopause are fine as well, but they get dry and they can get tacky because the water evaporates. And so when water evaporates, when you like are having to have sex a little bit longer, if your partner needs a little bit longer to have an orgasm, it can take it by the time it's done, you may not be feeling good because it may be feeling a little sticky. The other thing outside of something you put on yourself or add to yourself is just keep having sex. Like frequent sexual stimulation with yourself, with a partner, it doesn't matter. It brings blood flow into those areas and helps your skin and your tissue stay normal. It helps bring in like lubrication. It helps bring in vitamins and nutrients and things that you need. And so highly, highly recommend if you want to stay sexually active, even if it's just with yourself. That will help your vagina stay more like it was before menopause for longer. There are also I mean, I bet a lot of people have heard of these, but there's the quest for the perfect vagina, right? And there's vaginal rejuvenation techniques and all these funny words for it. And those are mostly the marketing sort of terms that we're using for it. But what it is there are heat or energy-based devices that can go into the vagina or on the outside of the vulva that can help regenerate collagen and give you back some of the thickness, the moisture, the durability of your vagina by using energy techniques. There are radio frequency that's been used for a long time, and it seems to help somewhat with bladder symptoms. It seems to help with vaginal symptoms and dryness. There's newer techniques that use microneedling and radio frequency, and those are, you have to use some lidocaine or some things to numb the vagina ahead of time. They don't hurt much, but they do increase the collagen growth, the stretchiness. They give you back some of that durability of the vagina, and it seems to last a bit longer. There are also laser procedures that go back longer. So the Mona Lisa is the one that most people know about. And that one works pretty well, but it's a little shallower. It doesn't quite go as deep as some of these other techniques do. And all of them need to be repeated, and all of them are cash-based. None of them are covered by insurance yet, for reasons I won't get into about women's health care. compared to men's healthcare and what gets covered. But these techniques are usually done 3 times. So you'll have a session of them about a month apart. And then that effect, depending on what your age and your tissue looks like, that effect of that thickening, more comfortable sex, more lubrication typically lasts at least about a year. Some women, it'll last almost 2 years. And then you need to do another session, meaning about once a year after this, you need to do a radiofrequency microneedling or laser treatment to keep up that tissue and keep those changes in place, that collagen strong, if you're not using like estrogen or something else. There are also women that are like, but Dr. DeWinter, I'm at a point that I can't have sex. I'm at a point that my vagina has gotten really small, shorter, because those changes happen to the vagina and the urethra, and I can't actually get a penis in because it's too tight, dry, and uncomfortable. So in that situation, there are things called vaginal dilators, which are progressively larger. They look a little bit like dildos, but they're basically silicone coated, typically like little instruments that go inside the vagina that you use yourself to slowly increase the opening size and the length of the vagina until you can accommodate your partner. This can happen after surgery. Your vagina gets shorter. It can happen because of menopause. And using those techniques, especially under the the advice of like a pelvic floor physical therapy provider, can be important and really, really successful in getting you back to sexual activity. I've had a lot of patients have huge success using these, but you have to be motivated to do them. You have to do them every day, or it's not going to work forever. So what works best for you? That I can't make that decision for you, right? I need you to talk to your doctor about it and see what they think. But in my opinion, I think vaginal estrogen and DHEA, which is intrarosa, you use daily as a vaginal medication, I think they work better than systemic hormones for the vagina and the bladder and the urethra. And there's lots of research studies that show that. For women, these systemic total body medications, they may resolve all your symptoms. And then you don't need to use them topically if you're already using hormone replacement therapy for hot flashes, right? If you're already using it and it works for there, you don't have to do both. But if you're at an age and your doctor's like, I'd like to take you off of those hormones that you're using systemically, you can still use the vaginal stuff. It is very safe. Those vaginal procedures, they do work really, really well, but they are not covered by insurance and they can be quite expensive. Usually they range for 3 sessions, $2,500 to $3,000, which is quite pricey. The effect of the hormone treatments and the procedures, they will go away over time if you stop using them. That is just something to know. If you did the estrogen for a year and you're like, this is amazing, if you stop using it 3 months later, 5 months later, 7 months later, it may not work anymore. So you just have to keep that in mind. It's something you have to keep on. And so that is my thought, my thoughts on things, and I'd love to receive any questions that you have.
That was fabulous. I learned so much, Dr. DeWinter. Wow. Is there an issue with use of moisturizers or lubricants, and how well a condom will protect against pregnancy?
For sure. So for women that are still having periods and they're going through the menopause transition, so they're having periods, but having dryness, but could get pregnant, that's a great question. Unfortunately, you need to use, especially for the lubricants, you're not supposed to use an oil-based lubricant with a condom. There's specific ones they're supposed to use, or it can degrade the quality of them. Typically, it's a water-based lubricant, but a lot of condoms come pre-lubricated. That is a good question. For hyaluronic acid and the other ones, I'm not totally sure if you're not going to be using them at the same time as intercourse. So generally, I don't think it would be an issue. Usually you're using them regularly right before you go to bed 3 nights a week. So most of the time it's not in direct competition with what's going on with the condoms, but you do need to be a little more careful with the lubricants.
Okay. And what is the impact for someone who has had a hysterectomy?
Yeah. So a hysterectomy, in terms of how it changes your hormones and how it changes your vagina. So losing your uterus doesn't mean your hormones are gone. It can make women getting closer to menopause go into menopause earlier, at least by 6 months. sometimes if you're right on the edge, you're 45, you have your hysterectomy, right? Then some people tip into menopause a little bit early. It shouldn't directly make you go into menopause because you still have those ovaries. It won't cut off all your hormones, but you may go through the symptoms earlier. It will just make your symptoms, your changes to your vagina come on a little bit earlier in time than they would have normally. But there don't seem to be any really bad long-term changes from having a hysterectomy versus not around that time. There's been lots of studies on it. It does shorten your vagina. So when you remove the uterus and the cervix from the top of the vagina, because that's where it hangs out, you lose like a centimeter at least of vaginal length. Most women have about a 12 centimeter vagina, 10 to 12, sort of in the premenopausal years. And if you lose the cervix, at least a centimeter, maybe a couple, depending on how careful the surgeon is, may get cut off and may get it shorter. And so the length can really change when you have a hysterectomy, and that can make sex less comfortable if your partner hits the very end and can't keep going, and there's not that stretch anymore. So that's primarily where I see the changes.
Gotcha. Okay, good. How about, will using estradiol cream 1 time per week be as effective as twice weekly, or at least help with the dryness?
It'll probably help, but it's not quite as effective. They've actually done some studies that show if you use estrogen a little bit more in the vagina, you absorb less into your bloodstream. So using it less often or forgetting it actually means more gets into your bloodstream than if you use it consistently 2 to 3 times a week. So if you feel like you're like protecting yourself by like getting less hormone in the rest of your body by only using it weekly, it does not do that. It actually may go the opposite direction.
Interesting.
Which is a weird side effect.
Yeah, for sure. So let's talk a little bit about UTIs and how quickly will the use of estrogen take to reduce UTIs?
It takes a while. Typically, I tell people at least a month, sometimes 2 months, and you have to take care of the immediate infection. So you have to get rid of the infection they have right there, which means antibiotics. And then you have to kind of get, try not to get an infection during that month where it's starting to change and you're starting to get the healthy stuff. And so during that time, I'll have a lot of people use cranberry with PACs in them. And so cranberry's been used forever for bladder infections. You drink the juice. The juice has a ton of sugar in it. It has a ton of other things. And if you can get a nice quality supplement that has 36 milligrams of PACs, proanthocyanidins, I can't even, that has been shown to reduce people's risk of bladder infections pretty substantially. So I'll keep people on something like that until they get their estrogen on board, and then try to like just use estrogen or try to take them off some of the other supplements that have shown pretty good evidence that they work.
Okay. Yeah, I've always heard about the cranberry juice trick, but
you have to drink a lot and you have to drink
Yeah.
it every day. And a lot of times people are actually picking up cranberry juice at the store and they're like, well, I've got my cranberry juice, but it's cocktail, right? And if you look at the first ingredient, a lot of those things, first
Sugar.
ingredient is apple juice.
Oh, really? Okay.
So you have to be really careful. It'll be like
Yeah,
cran apple or cran grape or whatever, and it will actually be mostly apple juice.
right. Like any products, look at your labels.
Exactly. Yeah. So you have to
Yeah.
get a sugar-free one if you're going to do the juice trick, and you have to drink a lot of it and you have to drink it every day. So the pills I think are a little nicer because you just have to take it once. It slowly absorbs through your GI tract and you get kind of constant coverage during the whole day as it slowly absorbs.
Yeah. So what's the best way to discuss the possibility that, my UTIs are an estrogen problem and that antibiotics only, that they won't be sufficient enough to control what's going on?
Yeah, it depends. So I consider women have recurrent bladder infections that are the ones that really would benefit from using estrogen for it, meaning more than 2 in 6 months. So if you get 2 UTIs and it's a different bacteria, sort of like you get an E. coli infection and then a month later you get like a Klebsiella infection or a different strain. That means you're really prone to getting a bunch of different infections. Those women often really benefit from estrogen because if you even do a daily antibiotic, if you have multiple different types of infections, you're going to get one of those that comes through and breaks through the antibiotics even. But estrogen it covers everything. It makes the acidic environment inhospitable to all different kinds of bacteria. So it's this beautiful kind of natural way to fight against every different kind. So if I see somebody with a bunch of different types of infections, I notice that their vagina looks atrophic. It looks like it has those changes. You're having more than 2 in 6 months or 3 UTIs in a year. Those are a great candidate for vaginal estrogen.
Okay. But how do you get through to a PCP about the possibility?
I have not had much success with that. I mean, I've given some lectures to the local ones. I think it's slowly penetrating into common knowledge. But I mean, even a few years ago when I was in fellowship, the urologists didn't really know how to use it well. And they're, some of women's first lines against recurrent UTIs, and they weren't aware that vaginal estrogen is such a huge tool for this. So I think we need to get to our urology friends and we need to get to our gynecology friends because they're the ones that a lot of the primary cares are sending people to first. Primary care, there's so many of them and they're trying to learn so many things. I don't blame them for not keeping up with it. It's hard to follow everything, but I think our gynecologists and urologists who see a lot of these patients should do better. I don't know how to get that information to them though. That's a challenge.
I know you talked about prolapse a bit, but can you go more into the symptoms of prolapse and when to see a doctor like you about it?
Sure. So prolapse, the first symptoms women often feel is, at least in the vagina, they like something pressing down or a heaviness, and they look in the vagina or they touch right there and they feel something. People describe it as a balloon or a wall or tissue, and they're like, just something is sitting right there near the opening that I can feel when I'm just standing or when I'm in the shower, or I pick something up and I feel something fall down or push down in that area. That's the like prolapse symptom. But sometimes it's really subtle. Sometimes they're like, I'm getting up all night to pee and I didn't used to do that, because they go to sleep at night and their bladder raises back up and then their brain can feel it. And so they get up and they can empty better at night when their bladder starts lifting up again. Or they're going to the bathroom more often, or they're not empty and the flow rate changes. They're like, I'm peeing, but like I used to pee like fast and it took me a second. And now I'm just sort of dribbling and it's shooting off to one side. Those are some of the symptoms that people have. Or constipation. They're like, I pooped really good in the past, but all of a sudden I feel like it's getting stuck right at the end. All of those symptoms can be prolapse. And all your doctor needs to do is look at your vagina and have you push down or cough a little bit. The problem is if you look in the vagina with a speculum, like when we're trying to look at the walls to see your cervix for a pap smear, you miss prolapse because you're pushing the walls away and you literally hide them from yourself. So you have to like open the speculum into two sides and just look at one wall at a time. And that's the best way to look. It's a less uncomfortable exam and it's the way to find it. Most gynecologists will find it. A lot of urologists do not do a pelvic exam.
Okay. Wow.
And I love my urology colleagues, but some of them are very prone, like taking care of women, really, really oriented in that direction, and some of them are not. So it's not a woman that's crazy that's like, I went to this doctor and they didn't help me and I asked for help. Just keep looking and keep pursuing because there are people out there that can help you.
Okay.
Yeah.
Is there anything different for women in a lesbian relationship?
There's often less penetration caliber, right? Some women that have sex with women don't put anything on the inside. And so there may be fewer symptoms in terms of the stretching, the burning, the irritation. But there may be more issues, sort of like I'm having a longer time having an orgasm, or it feels a little bit more delicate on the inside. But there's often a little less sexual dysfunction for same-sex couples than there is for heterosexual couples. Like a lot of times the men are starting to have trouble at about this point too because of their prostates and erectile dysfunction. Same-sex couples don't have that trouble. So usually their sexual function stays better than most heterosexual couples.
Okay. Good news
Yeah.
on that part, I guess. What about estrogen? Any help, in regards to pelvic pain?
So if the pelvic pain is from the lack of estrogen in the top layer of tissue, in the stretchiness, in that kind of components, it can be really helpful. But pelvic pain as a concept is so multifactorial. It can be the muscles, which estrogen doesn't help that much. It can help a little bit. It can be the organs. It can be your uterus hurts because you have adenomyosis or endometriosis. And so, like, estrogen's not going to help with that necessarily. It can be the tight muscles themselves that sort of clench up. And estrogen might make the opening feel better. So, sex feels a little better because you can accommodate, so you're able to relax a little bit more. But it doesn't directly target the muscles in the same way as like physical therapy, medications. There's nerve blocks, there's vaginal Botox, there's all sorts of things. Or if it's an organ problem, you have to fix the organ. So you need a gynecologist or a doctor that can really figure out where your pain is based on your symptoms and the exam, because nobody's the same and nobody's body sort of has pain in the exact same spot. But there are like big groups of things. Like, is it an organ problem? Is it a muscle problem? Is it a tissue problem, like the vaginal canal, the skin problem? Or is it the opening that you have a vulvar skin condition? And you need to look and feel each of those gently to be able to figure that out. Because just saying I have pain with sex or I have pain in my pelvis, that can be from so many different conditions, and not all of them are gynecologic.
Right, right. Well, I mean, it can go so many different ways, especially, with the pelvic floor muscle itself getting tight
Yeah.
or, yeah, losing its strength.
Yeah.
So,
So it can
well,
help some women, but not everybody. So if it didn't help, don't lose hope. That's just one component of trying to work your way through the ways to the layers that you need to take care of to make pain better.
yeah, and that's so important. Really be an advocate for yourself and continue trying
Yes.
to seek the right answers to your pain, your questions that you have.
Yeah.
So, all right. Well, I think that you have really knocked it out of the ballpark here for us, Dr. DeWinter. Covered a lot of amazing information.
A lot.
If you wouldn't mind going to the next slide, I would like
Sure.
to just mention to our listeners about some upcoming webinars that we have at the end of the month here in June 26th at 12 o'clock Eastern Time. We have our mindfulness mentor joining us to talk about, how you can find relaxation before bed. And she actually will take you through a mindfulness practice to help you, be able to relax yourself so you do get a good night's sleep. And then the whole month of July, we've got a really special webinar series coming up with Jane Ehrman, and she is going to do a weekly presentation starting July 9th, and she's going to give us all kinds of wonderful information on guided imagery for menopause. So you can see the dates here, and please, any of these webinars, and we'll have some other ones as well, you can sign up for them at our positivehealth.com/webinar site. And also on that page, you'll find all of our previously recorded webinars, including this one too, if you want to go back and watch this again. And then on the next slide, we have our upcoming podcasts. We release a new podcast episode the first Wednesday of every month. And so in July, we have one talking about Ayurveda. So how to feel centered and grounded and joyful with Ayurveda, because there's a lot going on in your life when you're in this menopause journey, and being able to understand how this might be something to consider. And you can see we have all of our podcast series available at your favorite channel here. We have Amazon and Apple and Spotify and iHeartRadio. So go find us out there, or you can find us on the positivehealth.com/podcast site. And if you are a member of Positive Health, awesome. But if you're not, or you know someone who could benefit from this program, feel free to sign up at the positivehealth.gomohealth.care/enroll is where you can go to get directly enrolled into Positive Health and make that change for the better, and get enrolled into this one-stop digital health experience that supports the body, mind, and spirit during your menopause journey. And just to note, it is free until December 31st with our pilot program. And then lastly, we have a menopause journey community. So you're invited to join in on this community, where you can hear other stories and share yours or bond with other women going through the same thing you are. Okay. That is a wrap, I believe, Dr. DeWinter. Thank you so very much for everything. I know you spent a lot of time and effort in preparing for this, and boy, did you covered a lot of information in regards to the bladder and the vagina and our pelvic health in general. So we really, really appreciate all your expertise here.
Perfect. It was a pleasure doing it. It was nice to see you today.
Yes. Thank you. And thank you everyone for joining. Take care.